Yes, okay, but we have a quorum, so I will call the meeting to order, and we will start with the minutes, which came in advance. Thank you very much. Any comments on the minutes? Hearing none. Alan.
I would just like to thank both you and Lauren for taking the time and trouble to meet by Zoom, because I had a professional conflict with the last quarterly meeting. And that was just so, I thought, gracious and welcoming of you.
We were happy to do it, and we appreciate the feedback and hope that we were able to accurately sort of reflect the feedback as part of that broader discussion that we had in person with the council in September.
Yes, and thank you for taking time. That was appreciated as well. All right, do I hear a motion to approve the minutes? A second?
Second.
Thank you. This has to be a roll call since we're not all in person. So, Brown.
Yes.
Niels.
Yes.
Where's Dana? Dana. There was one I missed. Eliza, you have a choice. You can either, according to Robert's Rules of Order, either approve, even though you weren't here, or
I was going to
you can
abstain.
abstain.
Yes.
Okay, Sandy. Yes. Jean.
Yes.
Alan.
I need to abstain also.
And I say yes. Terrific, thank you. I also want to now introduce Eliza, who is replacing Karen. Welcome, welcome. It's a good group. I have no doubt, having just had lunch with you, that you will not hesitate to pitch in.
Best I can. They're big shoes to fill.
Yeah, we will miss Karen. We wish her well. She was really here at the creation, at the beginning, and on the board in 2015, then went to Texas and came back. So has had a wonderful history. So I'm sure she can give you any advice if you need any. Okay, Andrew, do you want to join us? We spent most of our last meeting, if you recall, on the strategic planning update, and lots of good conversation, which I think was reflected in the minutes very well. Thank you. But this is an opportunity to see what the staff created, the input that they took, and where they're proposing to go forward.
Well, thank you. Nice to see you all again. As Faye mentioned, just a very quick recap to sort of round today's discussion. Last time we spent a good portion of the meeting talking about our strategic plan, so I'll sort of be brief here, but CHIA had developed its current strategic plan in the spring of 2023 to help guide our organizational decision-making through calendar year 2024. And the current strategic plan articulates CHIA's mission, vision, core values, 6 priority areas, and 4 primary goals and objectives. And as we developed the plan, we really thought of it as a sort of living, breathing document that we would be discussing with the council, and that we pledged to bring it back to this group as we entered the next phase. So as we are approaching the end of calendar year 2024 and thinking about sort of what lies beyond, again, we wanted to make sure that we had a touch point with this group, and that we spent some time today talking about some of the feedback that the council provided at the last meeting, and then sort of went through our plans to incorporate that going forward, just to ensure that we are aligned with the council's vision here. So these are some of our operating assumptions going into this next phase. And I think sort of at the outset, I will say that really we expect that going forward, many of the current priorities and themes will be extended into the out years. And that's really based on feedback that we've received from the council, from our sister agencies and stakeholders, which sort of led us to understand that the current priorities and goals sort of still reflect the priorities of our key constituencies. Also worth noting is the fact that really the majority, around 70% of those analytic project and staff capacity at CHIA are dedicated to statutorily prescribed work. And I think this is important, as we talked about last time, just in sort of noting that we have a limited ability to take on new discretionary work without sort of dropping or slow walking existing projects. And among the discretionary work that CHIA is, sort of has underway or planned includes our health equity agenda, our work on workforce, our work on primary care, as well as fielding the ad hoc requests from sister agencies in the legislature. So just important context as we think about sort of what we may add to the pile. So the next couple slides really sort of go into more detail about each of our 6 priority areas and the work that we have either planned or underway. And for each of these, I'll call out some highlights, and then we'd really like to sort of pause on each one to have the council confirm our plans or offer some thoughts on how we might refine our approach. And where relevant, I will specifically call out feedback that we heard from the council in the last meeting and how we plan to incorporate it. So this slide reflects CHIA's 5-point health equity strategy, which had previously been discussed by the council. We've been sort of notably looking at ways to improve our equity reporting by building on existing work and then identifying new areas of opportunity. So to that end, we have stratified previous reporting on spending and utilization in order to better understand disparate impacts. And we are planning to look at use of care in appropriate settings, the performance of important safety net providers, and affordability challenges among lower income populations. We are also in the process of developing an equity dashboard that will highlight some of the most relevant metrics across several domains. So this will be something analogous to the dashboards that CHIA has developed looking at primary care, behavioral health, and provider financial performance. And we see this as an opportunity to synthesize some of the work that we've been doing and sort of bring it together in one centralized format, as well as highlight some other important metrics that we have yet to look at. On the data side of things, we're continuing to advance our plans to collect socio-demographic data from payers. And we have recently started to develop a plan to reinstate the collection of both dental and vision claims. So, thumbs up from Faye. We've also been partnering with EOHHS to support its AHEM initiative. We've been advancing Mass Health's 1115 waiver by collecting demographic data from hospital EHRs. And we've been coordinating with the Health Equity Compact to ensure alignment of priorities. So there's more on the slide. Those are the sort of highlights that I wanted to call attention to. And again, I'd like to sort of pause here just to sort of see sort of what the council's reaction is and whether there are sort of other research topics or data stratifications or initiatives that we should be thinking about as we enter this next phase.
Yeah, okay, yep, Neil, you're on. We see your hand.
Okay, thanks. I just had a quick question on the expansion on the dental and vision claims data. What do you expect will be the criteria under which those affected carriers would be required to submit? In other words, what's like the threshold for who would and wouldn't be required to submit data under that?
I would say that those are, some of those details we're still working through as we're, I would say dental, we're further along just because we had been collecting them and so there's more of a framework. On the vision side, I think we are still in doing some due diligence, trying to understand who are the carriers and players in the space And that will inform where we set the criteria and thresholds. So I think it's a fair question, and I'm sure we will be consulting with our colleagues over at the DOI as we put some parameters around which of these dental and vision carriers will be subject to that.
Sounds great. Thank you.
On a primary care question, since primary care is so central to health equity, should I raise it here or should I reserve it for workforce?
There's even a primary care slide, dedicated primary care slide as one of our priority areas. So it's for
I'll be
you.
patient.
Okay.
Sandy?
Yeah, Andrew, can you share a little bit more about the coordination with the health equity compact and kind of what that's looked like so far?
Yeah, well, I think it has been a sort of ongoing conversation with them. It's sort of more than a sort of like formal partnership, but certainly as we had developed our 5-point plan, we had several meetings with them to sort of ensure that we were comprehensive and that there was nothing that was like conspicuously absent from our plan. We've also had a number of conversations with them as we've started to think about this effort to collect socio-demographic data from the plans, given that both the compact as an entity has an interest in this, as well as some of their sort of their leadership is from the major plans in Massachusetts. So again, they're just ensuring that there's sort of an agreement that this is an avenue that's worth pursuing.
The only other thing I'd add is, as the compact has been sponsoring like comprehensive equity legislation, they've been in close touch and asked for our feedback, and we've been working with them on the specifics of their legislation as it relates to new reporting requirements and measurement. So I think there's a whole section in the bill that has reporting, measurement, sort of evaluation directives for CHIA. And that was, we have those meetings and discussions to sort of validate, yes, this was possible, this is feasible. And I know that as going into the next legislative session, they're interested in reintroducing that legislation. So we expect to be in communication with them throughout the process to help inform and shape.
Oh, good. Dana, you're joining us. Can you hear and can you see us?
Yes, I can.
Welcome back.
Thank you very much. Happy to be back.
Any other thoughts on health equity? Did you see? Great.
Moving down the line, this slide represents CHIA's workforce agenda. Obviously, we know that health and human service providers continue to experience unprecedented workforce shortages and challenges, and so this is an area that we are eager to continue investing in. Notably, I think I would call out that CHIA had established a biennial workforce survey that collects data on 10 major health and human service sectors. And the questions in that survey include quantitative data on vacancy, turnover rates and wages, recruitment and retention strategies, and the racial composition of leadership and select occupations. We are planning to conduct the next iteration of the survey in 2025, and then we will have survey results published by the end of next calendar year. So related to that, we are also working on a separate outreach to capture some of the employee voice in workforce data collection efforts, specifically looking at recruitment and retention challenges. And so in the second half of 2025, we will be fielding a separate employee perspective survey. And then we continue to work with EHS and DPH on developing and supporting a supply side RN dashboard that's under works. I think those are the things that I would call out as highlights here. So again, would welcome any thoughts from the council on whether there are additional sectors that we should be including in future surveys, whether there's new or additional data or sort of new approach to reporting and publishing the results that we've collected.
On the nursing home side, it's my understanding that that's the one sector that's seen the least bounce back from the COVID losses of capacity and workers. Do we have a sense of the current shortfall, unfilled CNA and other positions, LPNs as well, and what steps could be taken to remedy them?
So the long-term care sector, nursing facilities, is one of the sectors that were covered through our initial inaugural workforce survey.
Yeah.
We do quantify vacancy, the average sort of vacancy and turnover rate amongst nursing facilities. We also can glean information based on some of the qualitative data that we received back around what are the recruitment retention challenges, what are the strategies that are working and that facilities are employing to help recruit and retain more of their clinical positions. And we do stratify by role and position, so we are able to see variances around CNAs, the vacancy rates at nursing facilities versus some of the other like home and community-based providers, for example. We can look at RN vacancy rates, and you're correct that nursing facilities, particularly with the roles that also exist at hospitals, CHCs, and other provider types, nursing facilities definitely have, without looking at the data right in front of me, I do know that they have greater challenges and greater gaps. I think it's the goal of putting that information out there, though, is to inform policymakers and the industry at large who have the levers to say, with pipeline, education training, reimbursement, all the various licensure levers, to take this information and use it to make informed, data-driven decisions. Less so for CHIA to say, this is how we fix the problem, but we're trying to provide the fact base to inform those policymakers and industry leaders that do have those levers.
Is there one accountable actor or individual or organization that owns the problem of the nursing home worker shortfall?
My view would be there's not one, because there are various places across state government.
Yeah, I mean, again, the EOHS has a number of initiatives right now looking at workforce, particularly in those contexts around nursing in particular, and figuring out career ladders. I know that they're looking at different levels of, there's discussion about different levels of CNA that can allow everyone to work at the top of their scope of their license. So I'm not sure I would say that EOHS owns the problem, but I would certainly say that we are, that there's a huge focus, because nursing obviously is across all sectors, that there is an obvious dearth of availability in that sector.
It's really not a question, it's more of a comment, because I do see it's here, overtime and contract employee hours. I think the measurement really should shed a light on sort of the movement of these critical service workforce from regular employment to this kind of what we call alternative workforce, which is the contract employees. Just to give you a sense, at least in our industry, the spending on contract employees now is exceeding 10% of the regular employment, and which is a huge cost problem. It's a quality problem as well, right?
Yeah.
And there's a lot of these critical people who have the option of working for an organization on a continuous basis, but they don't. They join these temporary agencies that charge them a lot of money well, pay them a lot of money, but to give them a lot of flexibility, if you will, right? And then part of that is because there are rules that dictate that certain, shifts that must be filled, and therefore the market has no choice but to pay for the higher cost. In our company, which is probably across the human services organization, for nursing, the use of temporary workers is exceeding 50%, which is completely unsustainable. So I would just say, as you look at the overtime and contract employee hours, we really need to look at by discipline and also look at the trends. And then really rise it to the level of, from a policy level, what can we do to sort of suppress from this going out of control? Because right now it's a one-way street. It doesn't come back.
Right. So a couple of thoughts and really more a question back for you on that. So through the workforce survey, we do cover a number of the human service providers, and we will continue to collect. So we collect contract employee hours across all of the sectors that we're surveying. So we will be able to look at trends. What are the sectors most impacted? Separately, we are through the hospital, and I know this is a little bit separate, but through our hospital cost reporting, we are collecting dollar amounts to be able to track expenditures. We are seeing that decline on the hospital, but less decreasing reliance on contract staffing. But I think to your point, I'm wondering, is there something, it's really a quality of how you, in order to make the case for policy change, you want to be able to show data that just as contract employee hours increase, quality decreases. I don't know if you have any thoughts about how you could potentially capture the quality element of it. And maybe it's not through the workforce survey, but.
Yeah, we could survey. So for example, we routinely collect what we call client satisfaction surveys. And then our clients are able to really, articulate their experience when it's a contract employee versus a regular employee. It's actually very, very sensitive. And then a little bit related to that point, I think we need to capture the spending, the translating that to the wage that is paid for contract employees as well. Because right now there is no regulatory intervention at all in terms of sort of how much they can charge. And then that is actually pushing the dynamic completely in the wrong direction. And then we don't see a mechanism for us to mitigate it. And then again, some of the disciplines are particularly urgent, nursing, on top of everything else. So so just that there is no mechanism for that problem to really correct it by itself, because we could raise wages, but we are always outstripped by what contract agencies will do. So the market just elevates. I know that the hospitals are in sort of slightly better positions to do that, but at least for the past several years, they have struggled to a lesser extent with the same situation. That's clearly a cost and quality problem. So thank you.
Great, thank you.
So here we have CHIA's work on primary care, which we know is important and can help reduce avoidable emergency department visits and improve overall population health. So to call out a few things that we've done in this area. In 2023, we published our first ever dashboard, which included metrics to monitor the health of Massachusetts' primary care system. And the dashboard looked at metrics across 5 domains: capacity, performance, equity, and finance. And the intention of doing this was really to help establish that factual foundation to support policy development in this area, which we know has been just an area of continued focus. Since publishing the first dashboard, we have updated it in 2024 with additional levels of data and granularity. We have also published a number of reports specifically looking at spending on primary care, so really digging into the financial investment in that area. And the 2025 workforce survey will include data on primary care practices. And so we've been engaged in a pretty lengthy outreach campaign to providers in the relevant trades to ensure their participation in this next round of the survey. So one of the things that came up in September from the council was this request that the agency prioritize looking at primary care supply versus demand. And I think based on some subsequent discussions, we've identified this as an area where we think it's important and we can play a sort of role in highlighting this issue and are committed to making progress in this area. I think so we're at the very early phases of defining specifically what that looks like, but we are sort of committed to taking this on. I know one of the specific requests that we heard from the council was to consider including metrics like rates of primary care physicians per 100,000 residents, rates of med school grads going into primary care. I will say that these are both metrics that CHIA has included in our primary care dashboard. So perhaps there are ways in which we could sort of better highlight that information. Again, we would sort of welcome thoughts on whether there are sort of other specifics that we should consider, other domains that we should be reporting on, or analyses that we should be conducting looking at primary care.
So, well, actually, Dr. Sager, you had a question before. So two thoughts about that, and in terms of thinking about equity. One is, and maybe it's because I come from Western Mass, but geographic equity and sort of, supply and demand is all fine and well to talk about as a state, but it means absolutely nothing if you live 50 miles from the nearest PCD. So that would be one piece, which maybe you already do, but I don't know.
So like a regional.
Yeah, some way of, and certainly I know that the DPH has their HIPSA data, the health provider shortage area data, and so they have some of that, and so maybe it would be redundant, I don't know. But I just think when you're talking about equity and access. And then the other piece in terms of access is if more and more PCs are going into concierge, care, that's not access for anybody. And so, what's the payer mix for various practices, in terms of mass health? I mean, HSN obviously is FQHCs, but because that's a huge equity issue for PCPs as well, if they actually don't have insurance, they don't take their insurance.
I think most do both, so.
Pardon?
No, most do both. Do both. You pay to be the concierge provider, but you also bill Medicaid for the process.
Right,
Medicare.
And I don't know if concierge has gotten outside of Boston or, I don't know anything much about that, but you just hear about that's where.
Do we know whether or not a provider is a concierge provider? I don't know how we know that.
It depends.
Well, you may not have
Which source, so we are not planning to, we're not planning to survey concierge primary care practices as part of the workforce survey. So they will be sort of outside of that survey construct. For the payer data, and I need to phone a friend over in the team here, if it's paid for by commercial insurance, it would be reflective in the spending data that we collect. But any caveats?
Only that I don't think we could identify unless the practice was exclusively, like unless it was like a concierge practice. I think that's the only way we could separately identify them. Because we get things at the practice, our names on the practice level.
Right.
I think this is, we put out a list of the practices about which we're collecting the data based on like revenue, size, that sort of thing. This is potentially an area that we could look into expanding our collection to say we want to source practices, even if they don't meet that reporting threshold, but they're concierge practices for the purpose of like gaining transparency in that area.
And I mean, I didn't bring up concierge as sort of like, that should be a focus, but just, when we're talking about access, when you're talking about supply and demand, somebody's insurance status could seriously, it might look one way in the community, but in fact, not in real life for somebody on the ground. Like, not their access.
Okay, your moment on primary care.
Several medium-sized things, please. First, fundamentally, do we count bodies, people who are declared in primary care, board certified, board eligible, or do we count visits or full-time equivalents in primary care? And that would get partly to the concierge. Also, we know that as the gender mix in primary care changes enormously, hours worked per week for legitimate reasons drops associated with child issues and other factors. So do we know the number of full-time equivalent primary care givers, physicians to start with? And do we know how many visits per week constitutes full-time equivalent? Counting bodies doesn't work. Does the Mass Medical Society have anything on this?
I think the best source of this data is probably Bourne, right? The Board of.
Yeah, and HIPSA, I mean, in order to get a HIPSA, they do reassessments of HIPSAs all the time, and that looks at, I think, some of those metrics, so it may be that they would be helpful with that.
Yeah, but I think this is part of the reason that we wanted to have this conversation, though, is just to sort of share, this is the work that we've done, this is some of the work that we're planning to do, but how can we, I want to hear from you how we can maybe integrate some of these analyses, because we know we're going out in 2025 to collect primary care data from we're really starting with the large organizations and practice sites. So if they're part of a larger system, we're trying to get at least, I think we understand that represents about 80% of primary care docs is those affiliated with some, one of the larger systems, MGD, BILH, UMass, and the like. So we'll have the quantitative data around vacancies, turnover rates, and the like from that survey data. Like we have sort of extrapolated data through as part of the dashboard that we're collecting around utilization levels and access, but it doesn't capture what you're looking for, which is how many, what is the shortage, I think is truly what you're looking for. A vacancy rate doesn't necessarily mean the shortage rate, if you will. And so I don't know if you have thoughts on how we could marry some of these different dimensions and data sets to best address the question that you're looking for.
It's remarkable how soft such an important area is, how soft the data are. So, for example, if we have a person who's a primary care doc working full-time in patient care, no administration, research, teaching, or other responsibilities, how many patients are they accountable for? We used to say 2,000. Harvard Vanguard was up to 2,400 at one time. But it turns out there's new literature coming out saying maybe it's only 1,400 that people actually are taken care of. Well, it would be good to, we can't calculate supply, let alone the share of need that is satisfied on the foundation of such soft estimates. And I think that's very troubling. And it's a national problem. It's not a Massachusetts problem.
I mean, the data source I know, because coming from where I come from, is FQHCs have to report all of that. They know the average number of visits per provider. They know the number of the panel sizes. all of that. That if you, their UDS reports every year to HRSA are like have everything, all of that, how many FTEs per patient, et cetera. So I don't know if that's a place, so it's a place to sort of, there's a structure there of how that data is reported. I don't know how you would get that from other providers.
I feel like we actually are able to calculate supply. I think what's challenging is then to understand how adequately that's meeting demand. You need to know both how many, like approximately how many individuals, each of those, how much of that of patients are being treated by that supply number. And how many people are out there that have not been able to access at all. And so there's sort of those two variables that need to be solved.
I wonder if the earlier reference to the all-payer claims database would be helpful. Because if we have claims on all payers,
Yes.
I imagine there's I should know this, and I don't. Is there a category for primary care visits?
Yes.
Okay, so we should know the number of primary care visits per month or per year.
Mm-hmm.
That would be interesting to integrate with the HIPSA data, ignoring the 3,500 number, which is a giggle.
And I don't know what level of specificity your surveys ask, but, most practices will know, third most available appointments, like how long are people having to wait? Do they have wait lists? There's all kinds of ways of measuring that. At a pretty granular level that show, because you have to do it for all of the quality, certifications that primary care has to do.
I think that makes it hard to tie it to a solution, but that gives I think give a good sort of measure of need is like, how long do you have to wait? How many, who's being denied service for how long?
Do we have some questions in the survey that we asked?
So
How hard was it to get an appointment?
we have it across a couple of surveys. So the survey that asks about access and how long have you tried to get a primary care visit in the last 12 months, things like that. That is in our MHIS class health insurance survey. So we can, that's a resource. The workforce survey will be a resource starting in 2025 when we incorporate primary care. And I think your point about the ABCD can also be a resource for quantifying the current utilization rates. I think the other resource would be the primary care, the aggregate payer data on primary care, which shows spending by commercial segment. And it does have some very high level aggregate data, but I think with all four of those, we can think about how to best achieve some of these numbers.
I think you have to be careful of the wait time, because different practices, they have their internal rules. For example, if it's with my primary care, for a sick visit, you can be seen this afternoon. With the well visits, it's probably 6 months when they set their own rules. It was really hard to get it reliable. I do think that the claims data analysis should be kind of a no-brainer, because the claims data has the patient, has the date of service, has the duration of the visit, has the provider ID. So we can know how many visits. The all payer is important because, most providers will have payer agnostic practice. So we have to be able to aggregate Medicare, Medicaid, commercial all together to do that calculation.
The natural limitation with the ABCD, regretfully, is that it's missing all of the self-insured, I don't know, but most of
So
the
there's still
self-insured.
gaps.
So there's gaps, yes.
I was gonna make a similar point to Jean, just based on the complaints that we get at the AG's office around access to primary care. I think that if we're building in new questions into the survey tool to try to get at some of those delays and access issues, I would strongly advocate for separating out, like, are you scheduling physicals, what is the wait, or for how long have you not been scheduling the physicals for your patients? Are you currently scheduling sick visits? What is the wait? Because it seems like those are very different
Very
issues, and on the primary care side in particular, like the physical appointments are so hard to get right now that you might find some really helpful data around like which entire practices may either delays or simply not scheduling. Right.
I was gonna say, I mean, just who's open to new patients.
You're right. Maybe do that by
That's pretty.
I would maybe separate that by Medicaid, Medicare, commercial
Yeah,
insurance, because it's not
exactly.
necessarily gonna be the same answer for all three.
It should be though. They're not allowed to differentiate, I think.
I know that there's secret shopper studies that have definitely found differentials.
Yeah.
And I assume this includes APRNs. It's not just MDs.
Yes, we are, for the purpose of the way that the questions are asked, I believe in MHAS, it does not sort of specify, it's, do you have a primary care doctor, is this sort of question one, and if so, have you been in the last 12 months, have you had challenges accessing in the last 12 months, so we can go back following this conversation to make sure that some of the questions are as granular and targeted as they need to be. But for the survey, we are very mindful that APRNs, you know, are their role in that care team is growing, and so we'll be looking at both the physicians, but also APRNs and the MAs and the different roles, and seeing if there are trends, rates, turnover rates.
Well, and I would just say in terms of patients, I mean, you know, there are people who refuse to see APRNs.
Yes.
And so your weights may be different depending on, you know, who people are willing to see. Yeah, and I think that that's changing, and I think it's, you know, in the market, there's, you know, lots of attention recently, it's changing. Yeah.
I wonder how receptive you would be to a request that sounds like this. Could we see at the next quarterly meeting, or before, better, so we could digest it and talk about it? Pardon me. A summary of what is known from the various sources of information currently available about the number of primary care physicians and nurse practitioners and PAs separately, about the number of visits they handle per year, maybe about payer mix, and also maybe about measures of capacity, responsiveness, time to next appointment for various purposes. Any measure of capacity and need, and the share of need that's being met by current capacity. Capacity, need, and the share of current need, of need being met by current capacity. And not going into depth on any new analyses, but just maybe wrapping up with illustrative data when conveniently available. What's already known.
High receptivity. Said high receptivity.
Cool.
To your earlier question.
Thank you.
We can, I think that is, we can pull all of those pieces together.
Also a good reminder for the council of what we do have, because you know what's in the survey, and remember what's in the ABCD, and remember what's in somewhere, and we don't. It's almost like a primer. This is the information. Here. Yeah, it would enrich the conversation. That would, as a step one, it would be a great start. Yes.
I feel like we were putting our arms around it.
No, I think that's a worthwhile exercise, given the interest and given this is one of the few topics that does feel like we're pulling from a lot of different places to piece together the puzzle. And it's not just a one and done data source.
Hmm.
And this will probably start a beautiful journey because I'm sure you'll be able to answer all of the questions yet, but at least we'll have a grounding now of
Yes.
what's available and what questions have been answered and asked. So everyone has been asked and are waiting to be answered.
And bringing in maybe the board of registration numbers and also whatever Mass Medical Society currently has. Because they in the past have sometimes felt under siege because Massachusetts has more doctors per 1,000 people than any other state. But then they say, well, they're not really available to see patients. So they've actually looked at that from time to time.
No, thank you. Yes, that's definitely doable for next meeting.
If we could see that maybe, if it's convenient, a week before the next meeting, because then we can read it and bounce it back and forth, and you wouldn't have to read it to us.
That's always the goal. So yes,
Yes.
we can endeavor to get that out
Thank you.
well in advance.
In the interest of time, because it's somewhat of a similar topic, behavioral health, equal issues.
Yes, and I will be very brief because I think our work in this area largely mirrors our investments in primary care. So we've produced a dashboard on performance across metrics. We have reported specifically looking at behavioral health expenditures, and we have incorporated a question into our workforce survey. So what we'd like to know from the council is whether there are additional domains we should be reporting on, new analyses, other considerations.
I just want to sort of make it's not much of a request, but just quality. I don't think that there is enough measurement of behavioral health quality. It's very limited to face-to-face follow-up after discharge, so it's events. But when it comes to patients' experience, and then they are just how happy they are with their, because I don't think, so the behavioral health patients are generally the least happy with their healthcare services received. There aren't that many patients that are happy with behavioral health, which I think is not necessarily sort of a surprise. I don't think that we collect enough sort of patient experience surveys about therapy. It's usually a measurement of physical access as a proxy for quality. That's actually not the case. Not everybody is happy with the therapies they're receiving. People switch therapists all the time until they can find someone that they like. And this has profound, roots. Some of that is the training of the workforce, the shortage of the workforce, just sort of general, for lack of a better word, sloppiness when it comes to, making services available as a society at a time when demand is increasing in all directions. So I would just call for some kind of effort to get a little bit deeper when it comes to collecting patient experience on how they feel about the behavioral health services that they have received, how happy they are, which I haven't seen a lot.
Right, because payers are using their, beyond the statewide aligned quality measures that, is it your understanding that payers are using different, like their own sets of quality measures?
So like we are a behavioral health provider, right? Very few people, not people meaning agencies, ask us, are your patients coming back after a crisis episode or an initial consultation? Usually they ask us, how often do you have a face-to-face follow-up after an episode? To me is relevant, but it's a proxy for something much more important, right? So it's just a sort of a dearth of kind of extensive quality information on behavioral health.
Yeah, I would agree. I think the other one that I know we were asked is, do you have a comprehensive plan?
Right.
It's all about process, but it
Yes.
wasn't about outcome.
That's right,
Mm.
yeah.
do you have thoughts on what it might be? I'm trying to like wrap through my brain to think of where is there the most standardized or centralized information on quality data? Because, yeah, I mean, it doesn't live within an agency, right? Because your organization, for example, is not sending up quality metrics. You have that internally, but there's no state agency collecting that, right?
I was gonna say, I think the ACOs have to collect hospitalization, VH hospitalization rates as one, it's not a great measure for, but I don't know.
Your data on quality measures, but it's limited to a certain.
Yeah, it's sort of data that doesn't quite exist. It could be, future efforts that we need to take to collect patient experience. Because there's a lot of patient experience surveys out there, but there's not enough representation of their behavioral health services. Other, sort of ways to think about is sort of how, because behavioral health is not always, but for the most part, sort of long-term care. Most people require ongoing access to their therapists or prescribers, and then how often people stay with the same provider, because we know that there is a lot of changes, chances, oftentimes due to dissatisfaction. Again, as I said, there's a workforce issue associated with that. So I don't think there's an easy answer to this question, but it's just sort of expressing a sense of sort of insufficiency in terms of our embracing the quality of behavioral health in general. There's a lot of talk about access, which is absolutely critical, but should we be talking about the quality through the lens of a consumer? Right. Yeah.
No, I think,
You love it.
yes.
One other thing that, when I looked through the behavioral health dashboard and both the sort of the static and the dynamic is, I know we can't sort of go and provide data along every cross-cutting sort of thing, but the age as a factor of behavioral health access, wasn't able to sort of get info about whether this disproportionately impacting different age groups and that type of thing from just the way that we were presenting on the dashboard. Not sure if something that we've been
Ratified at least some of the metrics. But let us take that back, because I know there's some metrics in domains that are stratified by age, but if you either want to send us what you were looking at, or whichever segment of it where you were not able to find any breakout by age, we can do some digging, or we can kind of do that expand of the dashboard and think through if there are certain areas that.
Do we know the numbers of social workers, psychiatrists, other behavioral caregivers who are accepting new patients covered by Medicaid, by Medicare, or by various private health insurance?
We do not have those, we don't have the absolute numbers here at CHIA. I think we have proxy data that go from the consumer lens, again, for NHIS, that indicates they've had a hard time or challenges accessing care. And then we have vacancy, turnover rates, that quantitative data from the workforce survey. But again, that gives you the void, not the number, not the actual number.
The Medicaid numbers. Under care providers accepting Medicaid?
I noticed, I knew it, this is where I say, I knew enough, I can go back and find out.
You can use that till next quarter.
Right, I mean, they're registered providers with Mass Health, but I don't know how many of them
I think the licensing boards collect or sort of purport to have information on sort of whether providers are accepting new patients. I don't know, I doubt that it is stratified by sort of payer type.
Right, right. And Mass Health, anyone that Mass Health is reimbursing is a certified provider, so we know the like the affirmative, the positive, how many are serving with Mass Health, but we don't know how many are practicing but are not taking Mass Health.
And so that, I mean, it seems like we could ask the licensing boards how many are licensed, and then ask Mass Health how many are taking Mass Health, and then come up with that delta, but
Yeah.
I don't know.
I'm gonna move us along to
Oh, if I could just ask really quickly, you say that you have payer and provider specific behavioral health spending levels. Do you also look at health safety net specifically? Because I think that that could potentially be very interesting if that's the first point of contact with the healthcare system, somebody having a severe mental health episode. Yeah,
HSN.
HSN,
The
yeah.
HSN is paying.
It's not self-pay exactly, but it is a way of capturing the uninsured and having behavioral health encounters. I think it would be interesting to look at that and potentially look at how many of those people then convert into Medicaid or another payer to continue their care.
HSN does not report in and doesn't, so we don't have the data in the aggregate payer data.
Okay.
And again, I'm gonna get to Erin here. As part of our annual report data collection, I know we capture HSN spending, but it's not broken out at the service category level, right?
Correct, we have just total HSN spending.
Okay.
And we do not have that subset by behavioral.
Okay. Is it possible to do the claims data? Do you have claims level, anything?
Not from HSN, but I can imagine HSN has it.
Okay.
But perhaps we can partner and then see if to enrich in our primary care and behavioral health reporting, if they are, they have any, but some of these services aren't HSN.
So just because, I mean, given that the vast majority of those are gonna be FQHCs,
Yeah.
right? So they should have that.
Yeah.
Again, I feel like there's nothing they don't have to report to us. So, I know you have to report it by payer, and there's, the federal doesn't have HSN as a category, but there's sort of other public, I think, is the line of spending. So it may be that they have that for the sort of behavioral health at that level as opposed to, that more acute.
To some degree, these topics are going to continue in the next one, on access and affordability, because they begin to all intertwine, so I have a need for.
Thank you. So this is our sort of portfolio of access and affordability issues, which is an area that we have been historically engaged in. And she has collected data on spending and utilization, premiums and cost sharing, high deductible health plans, and employer offerings. This is also an area where I think we see an opportunity to continue to make progress. So one of the ideas that came up in September was this concept of having CHIA examine underinsurance and administrative barriers to care. So accordingly, we will be including some new questions in our 2025 Mass Health Insurance Survey to capture information on medical debts that are past due or cannot be paid, as well as the consequences of struggling with medical debt or bills. We will also be adding new measures related to the use of HSAs and HRAs to pay for medical expenses. And we see those questions as augmenting some of our existing survey questions on things like churn, reasons for uninsurance, unmet need for care, and problems paying bills. Also, looking forward in our next annual report slated for March, we will be including a new and expanded chapter on access and affordability that will look at these issues through the lens of the individual and the family and their experience of sort of the burden of healthcare. And this will include a breakdown of total healthcare expenditures that looks at the percentage of premiums and cost sharings that individuals and families are responsible for paying. So we are excited about that. The council had also asked us in September to look at the impact of new drugs coming to market. Here too, we plan to incorporate this into our 2025 report on prescription drug use and spending report. Historically, we have focused on 10 classes of drugs that account for about 90% of pharmaceutical expenditures each year. And we have reported at the drug-specific level, the sort of number of prescriptions, the cost per prescription, and the total spend on these drugs. But we think that there's an opportunity and really some real value in calling out the new drugs as part of this analysis. So we'll have more to say on that as that comes together. As part of this request, the council had also asked that we look at the advent of drugs that will be coming to market. This is an area that I think we sort of share the vision, but it's one where we have sort of, we run into some walls in terms of legal authority and the availability of data. So absent some new legal authority from the legislature, I think this is one where currently we sort of don't see a path forward, but I'd be interested if the circumstances were to change. The council had also asked that we look at an analysis of urgent care and ambulatory surgical centers, including information on the geographic distribution and staffing levels. Again, this is an area where we have some limited data, and other agencies have actually sort of already produced this type of analysis. I know that HPC has done analyses of urgent care, retail clinics, and ASCs, their locations, the services that they provide, and the populations that they serve. And we want to sort of be judicious in how we use our sort of limited sort of staff resources. So I think we feel like this is best sort of covered by the HPC. Again, sort of wanted to bring this back since the council had asked that we consider this as part of our plan going forward. Sorry.
In that event, and certainly no one would want duplication. But I wonder whether it would be useful to begin to build an inventory of data availability, say by type of caregiver or by type of problem like access and affordability, pardon me, with links to the HPC ASC report. Let's see if we can talk entire sentences of acronyms. And the same for urgent care. Because I've had, even as good as CHIA's website is, it's increasingly difficult to find information that I knew was there and that I saw last month. Now that may be growing cognitive impairment, or it may be fun on the website, not found.
We share the sentiment that there's a lot of opportunity to streamline the website, and I feel very strongly about this. So I think as part of that conversation, I think we can, as we're gearing up for that website redesign, we can think about opportunities to create a table of contents or some sort of index that links out to resources that may not necessarily all be CHIA based, but links out to our sister agencies.
I think that would have tremendous value both for sort of external audiences as well as people within state government. When Chapter 224 was implemented back in 2012, there was a sort of resource that was developed for sort of staff that sort of looked across agencies and sort of had that sort of atomic level of data. It has not been touched since then, so I think the world has turned a few times since then. But I think there is some value in that type of resource.
Yeah, I mean, I was just thinking DPH has incredible data about some of these issues that we've talked about. Yeah, it would be really nice to be able to go to one place because it's really kind of like, where
But it's a hard problem, right? It's like and streamlining is not necessarily the operational, like categorizing and
Yeah,
just,
streamlining is
and
not the
keeping
right
up
word.
to date. It's like, there's just like, it's a very valuable thing to work on, but also really hard to do. And then once you do it, you have to keep it up to date.
And you have an intern job for the rest of it.
Yes. Yes, so that's a fair point, and I think, you know, that will be an undertaking, but we've earmarked resources to take this on in the next year or so. So we're excited, and we'll sure come back to you all to get feedback, and if you want to be data testers, it would be great to have fresh eyes on this as we're working on it, because I'm sure we'll be looking at it on an hourly basis, and so it will be helpful to make sure that the way that we're organizing and categorizing and collating things makes sense from a public user.
And life is often a matrix. So there are data on total healthcare expenditures, hospitals, nursing homes. But especially if other agencies are involved, the idea of listing data by type of survey, and then by problem or sector, like we were talking about physicians, primary care physicians earlier, or nursing homes, or behavioral health, or meds, that would bring in data from other agencies.
Yeah.
Once that were done, it might be easier by adding on, recognizing things are there.
You mentioned new MHIS questions and briefly alluded to administrative hurdles and accessing care. Are there questions on prior authorization, uncertainty around whether a service is covered, uncertainty about whether a provider is in network? I think these are areas where we don't get this from administrative data. There may be renewed or intensified interest in how people understand their benefits, and how much they struggle with things like prior auth and referrals.
Yeah, I don't know that there are specific questions like that get at prior authorization. I think there are questions about sort of reasons for not seeking care, and sort of like one of the options is uncertainty about whether this is covered by insurance, which sort of touches at that. But there may be ways in which we can sort of get more precise around.
Right, and I think the balance is it has to be at a certain, like there's a requirement, it has to be at a like
reading level.
yes.
Yeah.
And most people outside of this room,
Yes.
if you said, did you not get the service because it was not in prior auth? Would have no idea what.
And so I was wondering, is that a question for providers? You know, because they do know that language, and that is something that one of the, I don't know where or how, but
And make it short, that's pretty much finished.
right. Well, and the survey doesn't go to providers, right? It goes to households, so it's.
that, I was thinking if there's another sort of
There's
like
another-
employer surveys, there's something about.
KFS, they had like usable, like basically question wording you can basically recycle. We do that on the research side fairly frequently, so I can look around.
I've done some of the provider agencies, mass medical survey there, people all the time, what do you want to have with it?
And it's just definitely.
Keep going, Andrew. I'm sorry, Alan. Then keep going.
On the heading of out-of-pockets and affordability, this may be more of an AG issue owing to the illegal nature of balance billing in violation of contractual obligations with a commercial insurer or in violation of state or federal law. But someone told me they thought it was in 9 figures that caregivers would bill the balance of their charge, even though do we know if there are complaints about this brought to the AG's office? There are.
Absolutely, yeah, I mean, we did an entire, report last year about billing issues in the ambulance space, where we get a high volume of, balance bill related complaints. And our office has done enforcement work related to balance billing. I think if there are specific concerns or complaints, we would very much want to hear them. The AGO has a healthcare complaint form on our website, and folks are finding it. So we hear about many of these.
And it may be hard to survey illegal activity.
On that note, Andrew, keep going.
Okay, so very quickly, just other sort of concepts that were surfaced in September. CHIA is going to continue to help support the Commonwealth's health planning efforts, which have really been led out of DPH, HPC, and other agencies. And this will include ongoing initiatives to support the needs of an aging population, which has been led by EHHS and Elder Affairs. We will continue to work with sister agencies, including the HPC, to work on new affordability metrics and looking at opportunities to reduce waste in the system, which was another idea that the council had discussed in September. We'll pause there. I don't know if there's anything that we left untouched on this area, or if we should just
You've done a very good job. You still have one more topic. Keep going.
So provider financial transparency, another area that's sort of in the wake of recent events, we just, I think, sort of see as critically important to the work of CHIA. And to this end, we have recently consolidated some of our reporting of financial metrics into a single dashboard, which focuses on sort of some of the most actionable metrics. It includes both hospital and health system level view of the issues. This data has been used to provide quarterly updates to sister agencies to better understand overall performance and stability of the market and individual providers. And using this health and hospital system framework, CHIA is currently developing a consolidated dashboard for nursing facilities, which we sort of touched on last time, in which Liz Almanzor will sort of speak to in greater detail in a couple minutes, next on the agenda. And relatedly, CHIA is working with DPH and other agencies on the implementation of a recently passed long-term care bill. Specifically, we're looking at how to support the financial analysis of facilities and their related entities as part of new suitability review requirements as part of licensure agreements. So that was a lot very quickly, and I will pause there just to ask the council whether in this specific area there are other provider types that we should be focusing on, specific financial metrics we should be looking at, or other things that we are perhaps missing.
Good, you've exhausted us.
Sign up.
And we are going to talk about the nursing home, nursing facility report. Thank you.
Thank you.
Terrific overview. And really, if I think about how much work is in these short sentences, and I think about the resources you have, this is a very rich agenda for 2025.
So we will continue to sort of report back as this sort of gets memorialized in the plan, and then we start to.
And I also want to add that we are cognizant of the fact that, you know, there are always legislative demands, issues that come up that can push something off.
Thank you all.
It's coming up. Go for it, Liz.
Teed up
Take your
at
time.
a perfect time for that. Awesome. So again, as we have mentioned, and sort of what I've been here to speak about a few times, the last few council meetings, is this nursing facility transparency dashboard that we've been developing, that we are sort of excited to share a little bit more about today. I know one of the things that sort of has come up in the past has been what this is going to be used for and how this is used. And I will say, you'll see as we developed it, it's taking data that we've already collected either at CHIA, at a different agency, and trying to put it in one place that stakeholders, policymakers, et cetera, can get at. We are hopeful to make it sort of user-friendly to anyone that's interested, but our primary focus has been to make sure it's available to the policymakers. And so, as mentioned, it's just the note that sort of the first iteration, the facility level view, is expected to be published in January, and this will include 2021 to 2023 data within it. And then we will head into our next iteration, which is looking at the related entities. So this is a sort of quick sneak preview of what the homepage is gonna look like when it leans on. There are six buttons here that will be able to click into different views of the data that we're gonna share. So you'll see in the top left corner, it says nursing facility overview. That's actually gonna provide a map where you'll see where they're all mapped. You can hover over it for various characteristics about that. You can look through it based on the region they're in, the quality score they received, the actual facility, if that's what you're looking for. So there's sort of a visual view to start. The second piece is what we've brought to the council a few times and mentioned, which we call the profiles, something we do for the hospitals. It's really an individual view of each facility. And so it's going to include a lot of their characteristics, their financial metrics, quality metrics, things in one place for you to view on that particular facility. The resources section is something that we are currently building out, which will really have links to other data, links to data if it's not CHIA data. It will have links to the actual cost reports. So it's going to have sort of a next step if you really want to dig into some of this data further. And then the bottom three buttons are what we're calling industry level data. So it'll have revenue, expenses, margins, and utilization using resident days that you can see first at the industry wide level and then dig down into different breakouts of that data. These are our true sort of screenshots of where they are right now. These are what we're actually have worked through. So this would be the profile view, as mentioned. It's going to be one facility's view of all of their data in one place. It has the characteristics, things like their licensed beds at the time, the last reporting, their average daily census, the FTEs they reported, where they're located, all of those things. And you can use this to also filter by region, by the management company that they're affiliated with, to then get down to a facility level specific. And then this is sort of a couple of screenshots of what we're calling the industry data. So on the left side is the total margin view. So you would see a facility mapped against the statewide median and the 25th, 75th percentiles. And then below actually maps all of the margins of all the facilities. And you can use that to highlight specific facilities. You could look at it by tax status, so either for-profit, nonprofit, as well as their quality score.
So you can hover over, is that right?
Yes. So you'll see all of those sort of have like filter buttons almost, and that would allow you to highlight specific facilities or different, you can change the view.
And that blue line is just a bunch of dots.
It's a lot of dots.
To the ends, it's just-
That is, you start to find they move their way apart as you get to the ends. And as you hover over it, it'll have actual information about what the profit loss was, where they're located, some sort of further information on each of them. And then again, similarly, we have what we're calling the utilization, which is really the resident days by payer. And that starts at the full sort of all nursing facility level, and then you can dig down by specific regions or specific facilities to get to more data. So that's sort of our aim, is to take all this data, make it usable, and the user can sort of use a lot of these filters and highlights to actually see what they may be interested in.
Any questions?
Yeah. It's a microcosm of some of the things we last talking about. Where do you put it, and then how to go to a different agency? Cool.
That's another question. For a first meeting, I'm talking a lot. I'm just interested, the linkages, I mean, we've been talking about workforce, talking about nursing facilities. Is there any, and I don't know your other dashboards, is there linkages between, you know, financial status and workforce? Just thinking about a profile, I mean, when you're looking at a profile, it could be interesting, not to make more work for you, but just it could be interesting to see what those relationships are.
And I think it's completely that. So on the profile itself, for example, we'll also have hours per patient day on there. We'll have the FTE. So we are bringing workforce metrics into the profile.
Oh, I see.
And then at some point, that resource section that I mentioned is expected to also go out to that other dashboard to get where there's sort of more information, only because they don't speak sort of one-to-one, I think, with each other, but it could provide more information. But there will be the hours per patient day information, the average days, so it will get at some of that information.
It's very small.
Yes, that is completely fair. It will be live next month and you'll be able to use it, I think, at your leisure, so, in a little bigger screen.
Hours per patient day, is that reported by the home or does it come from payroll data?
It comes from payroll data.
Good. Do we have an easy way of assembling number of nursing homes, licensed beds, average daily census, occupancy rate, like for the last 10 years, statewide? Or does DPH have that?
Easily, I don't know that the answer would be easily, only because the licenses change throughout the year. At least from our, from our perspective, the license beds could change within the year,
Or say on January 1st.
of a specific
Yeah.
year. I think it could be, I don't think it's currently assembled sort of in one space in that regard. And I think that's actually where we're getting at to some of this sort of next step of what can we do for next year that would add to what we're building? So a lot of this, I think, gets into that discussion of here's sort of the first iteration of what we're putting out, which does include some of this, but maybe doesn't get it all of it.
Liz, it's okay to say that there's another agency that might be working on that?
Yeah, DPH is the sort of holder of the licensure
Yeah.
data for nursing facilities. And so, again, I don't know the answer to the question of easily assemblable for the last 10 years of like licensed bed days, beds on heads, like some of the metrics you're talking about for 10 years, but they're the holder of that data.
I ask because the changes have been so enormous and consequential and little discussed. Apart from nursing home closes, residents suffer emergency relocation, loss of friends, loss of access to family, the horror stories.
Yes.
But we don't have the background information, just those key measures.
I'll send you a link. There was a task force, a nursing facility task force that concluded their work in 2020. And a lot of the discussion was sort of the historical context, where we are, and a lot of what you're looking for, I think, is in some of the materials that were circulated.
So we just need 4 more years of data. Cool, thank you.
Anything else on nursing home? Thank you, Liz. I know this was a heavy lift.
This is great.
It always looks easy at the end when you throw up some science, how you do magic. Well, we're here. Is there an acronym for those? Are they FISHI or something?
That one doesn't roll off the
CHIA.
THC.
Shame.
Rolls off.
Yeah. Molly. So this is a question that, actually had been asked before, which I thought was fascinating. So Molly's gonna explain to us the difference between the numbers.
Yep, to
So
the best of my
everyone knows
ability.
what the two acronyms are.
Okay, so every year, CHIA calculates total healthcare expenditures. We're all very familiar with the THCE calculation. We're working on the numbers for 2023 now. So THCE is Massachusetts-specific, statutorily defined measure calculated annually by CHIA to monitor healthcare cost growth and cost containment goals. So this is the total that we then divide by the census population and assess against the healthcare cost growth benchmark. Another measure of total statewide spending is also captured in the state health expenditure accounts. So these are published by CMS every 5 years for the purpose of cross-state comparisons on healthcare spending. So these are sourced and calculated using estimates from the US Census Bureau's economic census, industry surveys, with some supplemental claims and budget data from public programs. So just jumping back, so THCE, we get that data, so we source that data directly from private and public payers, so all commercial payers and Mass Health and Medicare submit their spending data to us. So because we source this differently and they have different purposes, there are some major methodological differences in the calculation of THCE and SHEA. So here's a top level outline. One of the major differences for THCE is that this includes the net cost of private health insurance, known as NCPHI. So NCPHI, not to get too in the weeds, is the difference between spending collected by health insurers on premiums and that spent out on claims. So that difference, what's left over after paying for members' medical care. So this is only in THCE and not in SHEA. Also, THC is limited to medical spending that goes through an insurance company and only represents those payments from payers to providers. So it's only captured if the claim is through insurance. And then also we have spending, also additional spending from Mass Health supplemental payments, the Health Safety Net, and the Veterans Administration. When we look at SHIA, this is kind of a broader measure to estimate household spending on all medical services. So this includes spending for over-the-counter drugs, dental, vision, and these services not covered by health insurance. So this is spending not included in THCE. Additionally, SHIA also includes other third-party payers and programs not in our measure. So things like workers' comp, worksite healthcare, vocational rehabilitation, there's a whole list of them. Next slide, Alex. So because there's a different methodology, there's a difference in the totals that we get for THCE and the CMS measure noted up here. So it comes to about a 31, when we exclude NCPHI from our measure, we still see a difference of about 31.2% when we look at per capita spending. In 2014, CHIA worked to publish a technical note outlining the difference in THC and CHIA on the 2012 expenditures, and was able to explain away 22.76% of the difference. So for example, 11% of the difference represented those lump sum payments from other third-party payers and programs. 10% was explained away by out-of-pocket payments not captured in THCE, with the remaining explained away by the dental included in SHIA, but not in THCE. So that leaves about 8.5% of the difference between the two measures not able to be itemized. So SHIA is 8.5% higher than THCE that we cannot explain. So we did a quick back of the envelope calculation using calendar year 2020 data, and we found that the gap between our measure and CMS measure was approximately 36.2%. So still a pretty significant difference, but the difference is only a few percentage points higher than the 2014 analysis. So assuming all things being equal, we would be able to explain away about the same amount of THC, the difference between. Any questions?
It was very impressive in 2014, we had actually.
Yeah,
did
it was done 10 years ago, so I had to do a lot of reading on.
We're all gonna use the, analysis, because we weren't there then.
Yeah, basically.
I've been off and on interested in this for quite a while. And I think that the 2014 report was terrific, clear, useful. The idea of redoing it, I think it's time. The suggestion has been made, and I think it's a reasonable one, to wait until CMS releases the data through 2024. But by my calculations, and they're probably cruder and have less of the important information than yours, the gap between THCE and SHE has widened considerably, and more considerably than you found. But I may have left some items out, and maybe if it's appropriate, we can talk directly.
Yeah, I can share them out with you after if you want. Yeah.
Thank you.
Yeah.
Also, I'm concerned about this because unintentionally and by state law, THCE makes healthcare spending in the state look much lower than it really is. Even if we buy the 36% figure, I actually got 58% when you divide the difference by the Massachusetts figure, not by the federal figure. In other words, the federal estimate is 58% higher as I got it for 2020. For 2020.
Yeah.
It just depends on which denominator you use. But when we see reports in the newspapers, I don't know if anyone reads the newspapers anymore, but that show 71 billion, when maybe bringing in not just state health expenditures, personal health care, but total health care expenditures It may not be 71, it may be 125. And people who care about policy should care about that, not just when tragically a United Health executive is murdered. Horribly. There's a big problem, and unintentionally, using the word total makes people believe it's actually the total. That's not our intention. The agency is following state law. But total isn't total. And reporters don't know that. And does the governor know it? Do voters know it? I doubt it. Not to cast aspersions on anyone. So, what do we do? Especially when the HPC has a hearing 6 months after we release the data, and they get headlines for the same number.
Right, we're all using the state construct.
Right.
So that we're putting out year over year and measuring from an apples to apples basis, even if it's not the same definition and scope of the federal.
Right.
You know, we can compare notes and understand which denominator you're using to get a different calculation, but further, we hear the ask to update the analysis, and that's something that I think we're open to doing. I think it's a separate question as to whether there's interest by the legislature and others to change the definition. I think that's a different question.
Yeah, I didn't mean to raise that question at all, because the benchmark is calibrated to the numbers that are available from year to year. And I think that totally makes sense. But I think it's a matter of, we've got this benchmark and we measure whether we're under or over. Maybe who's culpable, maybe not, if we're over. But wouldn't it be useful to say, well, this is what's reported for Chapter 224 purposes, legitimately and appropriately. But at the same time, it's worth noting that when we bring in the data from the Office of the Actuary, CMS, that the number's way higher for Massachusetts than the state law defined THCE. It's a technical term. It's not really the total. To make that clear publicly. And I think otherwise we're burying numbers, not intentionally, but our reports have the effect of burying numbers. Absolutely unintentionally.
I think it's an interesting question. In the sake of time, let's think about it a little bit. And I'm trying to remember back. It seemed to me at the time, well, you don't want to include over-the-counter drugs. You don't want to include the fact that my kid just spent $800 for a pair of glasses because she wanted Prada. You don't want to include, so, you know, thinking through what's in and what's not is a broader question that I think is an interesting one as well. So we could talk about this for a long time. So I'm going to table it for now and ask us to think about it and come back, but obviously worth talking about it more.
Yeah, I don't think those are important sources of the difference. They are real. They're real, but I think across 7 million people, I don't think that's a big source of the difference. By the categories I've looked at.
I don't know.
Yeah, but
I don't think we do know, so that's part of the question I think you're asking. I think you're right. I think we need to think a little bit more about it. Probably not answer this question in the next 5 minutes. But think about it next time. And there was real work at the time about what got in and what isn't in, I remember. And it'd be helpful to do that as well. But thank you. This was a terrific answer to the immediacy of the question. Appreciate it. And we have 2 more topics we want to cover. I love the activism. Somebody earlier said, oh, this looks like an easy agenda. We should be out there 3:30. An important executive director's report.
Magnolia is one important and exciting update that's not on here, but I am happy to report that we recently just signed a new 10-year lease here, staying at this building. I want to give a shout out to Tanya, our Chief People Officer here, who has been on this journey working with the building. We are thrilled to stay and not have to pack up all of our hardware and IT infrastructure and move elsewhere.
To Boylston?
Yeah, we're not going back there. We'll take this side of Boylston. So that is an exciting development since I think we last met in September. All right. I wanted to cover a couple of updates since we last met. The Health Policy Commission, as many of you are familiar, they held their 2024 cost trends hearing, which every year CHIA joins them, as well as colleagues from the Attorney General's office. The hearing, the theme of the hearing is really sort of post-steward and how we can continue to advance and promote affordability while ensuring patient access and quality. I'd say emerging from the cost trends hearings and themes that were reiterated and reinforced throughout the day were around the need for comprehensive health planning, the importance of investing in primary care, and the continued and urgent need to address health inequity. So I'd say if I was to sum up the three loudest themes of the day, those would be it. On the budget and sort of legislative front, we've been working with ANF as to submit our FY26, which just sounds crazy to say, but our FY26 budget submission as ANF is working on in developing the governor's budget, or House 2, as it'll be referred to, that's expected to be released in late January. On the legislative front, again, since we've last met, we've not seen a comprehensive healthcare bill emerge from the legislature. I think that was the bill that we've been watching, and I think has the most, the volume of directives for CHIA. There's still a few more weeks left in session, but if it's not addressed, taken up in the session, we'll be watching as they gear up for the 2025-2026 two-year legislative cycle that will begin on January 1st. There were a couple of smaller bills that were signed into law since we last met. One was the long-term care bill, and that I think was referenced earlier. That does have some new responsibilities and roles for CHIA, primarily supporting our sister agencies in providing financial analysis and review as one component of DPH's suitability review for not only facility licensees, as well as the related entities, such as the management companies, which often have a lot of sort of ownership and actual interest in these facilities, as well as the realty companies. So we are gearing up and working with DPH. This is all very much sort of complements and advances the work that Liz and team are working on. So I think this is very complementary.
Do we or anyone have the capacity to measure tone of revenue to related entities to make profits look small?
Now that is a multi-billion-dollar question. No one has dug up or excavated the tunnels just yet, but we do feel like there are some new levers, authorities, and tools in that bill that will allow us to do a little bit of digging here.
Benchmarks. If you're paying 3 times as much per ton of laundry.
The laundry in particular, I can't tell if this is a metaphor or.
As an example.
I have absolutely no idea about tunnels and laundry.
I think we are looking to establish some sort of reference benchmarks. I mean, in addition to a lot of the metrics that Liz previewed, days cash on hand, debt ratios, which will certainly be included in the assessment. I think there are other metrics that we plan to look at to say, okay, how much is this facility paying in management fees per month? And if you see a facility that has really low staffing ratios, let's say like a really full, high occupancy rates that are really financially struggling, but they're paying 3x in management fees to their parent organization, those will be red flag indicators, for example, that will be used to support the assessment of these facilities by TPH. And their related entities that they are sending those fees to and that we know are really the ones calling the shots on the ground in terms of operations. So we'll have more to update, you know, on the tunneling and the excavation work next spring as this work advances.
Mm-hmm.
Another bill, just to note, there was legislation passed that expands coverage for breast cancer screening. And this was something that CHIA had previously done the mandated benefit review and cost analysis on. So we were all sort of excited to see that go into effect. And then again, as we gear up for the next legislative cycle, you know that there's a lot of sort of renewed interest in primary care, looking at drug costs. So we'll be, a lot of the perennials will be watching and waiting and here to support sister agencies and legislative partners. All right. And on the EAPCD project update, I think a couple of milestones to note. So the data warehouse environments for both the development and QA have been completed. So we're now beginning to load the data and test code in development. We've also made a lot of progress on the BI tool. We've completed a proof of concept that worked well. So now we're building the data models that would go in and source that BI tool. And then finally, we're in the process of procuring flexible analytics. And again, the flexible analytics for the EAPCD is a key component that will enable sort of ready and approachable access to do complex and nuanced data queries. It's that you don't have to have a PhD in data science to be able to run the code or the query, but the flexible analytics together with the BI tool, we are hoping that day-to-day analysts will be able to query this massive data set and run different permutations of analysis.
BI?
Business intelligence tool, yes. So that's sort of the interface when someone sort of logs on. So I think to some, I would say the project is largely on track. We had some delays related to hiring of developers that, which I would say set us back about 2 months from overall project timeline. They are now in place and we're in a strong position to hopefully make up for some of that lost time. But as of now, we are largely on track, albeit maybe 1 to 2 months behind overall project schedule.
Which is really a big deal. And I know I say this for the 10 minutes we have to give to the APCC, but I know that it's a vast majority of time, effort, energy, and in so many ways for your team. And it's always a slog. Big project, yes.
But we've got a whole team of folks that have been in this for the long haul, and I think there's a lot of commitment to see this through. And I think I would say renewed energy in this after feeling like this was a never-ending project.
I think we always felt, it starts out everybody's enthusiastic, and then you go into the valley of despair. And then maybe you see light at the end of the tunnel, and I feel like we're beginning to see some light.
Yes, this is going back to tunnels, yes.
Yes, thank you. Yeah, it's great, and thank everybody who works on it.
So the all-payer claims database issue solved your spare time problem.
Oh, yes, exactly. Well, I think going back to the earlier conversation around using the ABCD for analyses like looking at primary care utilization, like right now we have the ABCD original, which is still available and available for query, but it requires much more sophisticated person to be able to go in and it's a little bit more rigid. Once we have the EAPCD, and we're still in the market for a new name for it, so we'll be taking suggestions from the council. But that will allow it to be a little bit more sort of agile and flexible in the types of queries. And so from a resourcing standpoint, hopefully those queries and types of analyses will be able to do it much more efficiently once that is up and running. And again, projecting, I think we're targeting July of 2025, if we're now probably looking at something closer to September.
Fall.
That will be helpful in the resources, yes, fall.
Well, and you start with problems, guy working with IT secretary, the data you ask for is not the data you want. The data you want is not the data you need. The data you need, not available. And it's true, this will happen.
Yes, yes. Any other questions on this side of the practice?
Okay, any other questions before we move to the publications? The executive director, anything? Great. Publications, huge amount coming out all the time.
Yes, we've got a flurry of publications coming in the next couple of weeks. So tomorrow we'll be releasing our 2024 Massachusetts Employer Survey, which was a big undertaking, and we're excited to release this because I think it was, we haven't done the survey since 2021, and even that cycle was a little bit interrupted by COVID. And I think the key takeaway from that survey is really, we have a higher offer rate from employers than the rest of the country, but our premiums are higher, and the amount that employees are contributing is higher than the rest of the country. So we know we know we have a cost problem here. We know that employers are are more and more challenged from a cost standpoint to offer insurance, and that the employer-sponsored market is actually shrinking, particularly on the merge market side. So a lot of landscape dynamic shifts, but I think this next iteration of the survey will help to better quantify and provide that fact base to the next iteration of policy discussions on this topic, which I know will be largely front and center going to the next session. We also have the all-payer, the readmissions report that's coming out later this month. We have the human service data from the healthcare workforce survey coming out later this month. Quarterly hospital and health system financial reports, hospital profiles, and then the nursing facility dashboard that Liz previewed, that will be coming out in January. And I think since we last met, we've had one quarterly hospital and health system release of financials, as well as our quarterly case mix updates that were released. So a number of things that we've had a lot of publications in the last quarter, and even more coming in the next 2 months.
Even more than the 3 that the least published. Done a lot this quarter.
Yes. Depending on where we, come, the quarter start, yes.
Whatever you want.
Yes.
Okay, questions? Any questions on this before I wrap up? Great. Thank everybody. This was a wonderful conversation as always. I'm not going to summarize absolutely everything, but I think what I've heard for us is, or make sure we remember, a real good conversation, particularly about the shortage of providers and primary care providers, with some good questions to look into. A request for an analysis of various sources of information and where they are, which I think is probably the first step, just at least beginning to educate all of us on where the all could be and what is in them. We're going to talk a little bit more about the website. I think there's some suggestions on that. We're going to have a conversation on the metrics, the 2, and continue that conversation that I cut off. And I think that is probably the highlights of the conversations, lots of questions underneath that we'll get back to at the next meeting. Did I miss something?
Not at all,
I thought you were raising your hand to say.
yes. but it's new business.
Okay.
It'll take about 30 seconds. I have a motion, which is that the Oversight Board acknowledges the fine work of this agency and congratulates our executive director and entire workforce on doing a terrific job.
Agreed.
Is there a second?
I don't think you need a motion. You have a lot of smiling faces, but we will make it a motion, put it into the minutes. And you can share it with the staff because we know that it takes a lot of people to make this happen. And the amount that we just talked about, the 2 hours and the work that went into all of that. And the other things we don't even know about. And the size and the support you've got is, in comparison, is really a wonderful model. So couldn't agree more. And I think really the team and the broad team, and let them know. I appreciate it. Have a great season.
Thank you, John.
Oh, I'm sorry. Thank you. You got so enthusiastic. A motion to adjourn?
So me.
No, all in favor? They're already packing up. Thank you all. Enjoy the season. Thank you so much.
Thank you very much.